Hi there. How's it going? We are on our last Support Sunday today. We're going to be talking all about mom health with Dr. Sherry DeSchaff. And I'm going to bring her on. It looks like she's already here. So hold on, let me add her in. Hello, can you hear me?
I can.
Oh, great. Welcome. Oh, you're all set up. You're ready to go.
Yeah, I kind of have the lighting and stuff figured out from doing a lot of virtual visits lately. So,
We're prepared. We are all learning, right?
yes, it's been fun actually.
Yeah. Yeah, I know. I've learned a lot and never thought I'd be doing things like this. So
I know.
here we are.
We're like we are hands-on, both of us. We're hands-on professions.
Yeah.
We're like person to person, and I know you probably feel like me. Like I'm so happy that we have the technology to be able to still see our clients
Yeah.
for this time. But man, I miss being like right there present with somebody.
Oh, my gosh. Yeah,
Yeah.
for sure. That's been the hardest part. So, yeah.
But this is great. I mean, it's so great that you're doing this because
Yeah.
it helps people to still just keep some community and
Yeah, yeah, and these are things that don't go away just because the world has stopped, right? So, oh, and it's
yeah,
actually probably a lot easier to do this than like come in person. So hopefully we'll get to reach even more people this way. So
yeah, yeah. The reach is huge.
yeah,
Reach is
so excited.
education.
Yep. All right, great. Well, let's go ahead and get started. We've got people joining in. So welcome everyone to our final Support Sunday. As I was mentioning, we're going to be talking about mom health and taking care of our bodies after we have had a baby. And physical therapist, Dr. Sherry DeSchaff, is here with us. And she's going to be hitting the big hot topics. We will be taking questions. So please, be writing in your comments. We'll be taking care of those. She's already received a few beforehand that she's going to address. But feel free to jump in if you have specific questions about the topic she's covering or even about other areas that you need help with. So she's here to help. So I'm going to hand it over to you. Go ahead and get started.
Awesome. All right. So, I love to talk to people. I'm one of those weird people. I love talking to big groups. So, I can talk about this stuff forever. So I often will talk for a couple of hours about these topics. And I had posted, if you guys, any of you saw my post, there are 5 things I kind of usually like to hit with moms pertaining to your bodies and the changes after having kids. And I usually would love to go through all of them, but in the time that we have, were 3 in specific that people had asked me questions prior. So I'm going to kind of try to focus on those top 3, but then I'm happy to answer specific questions afterwards about the other topics. And I have an an online workshop that's free. It's 2 hours long. You can link to that in my bio. And you can sign up and watch that for free. And that's, again, you get to listen to me talk for 2 hours. So if you're not sick of me after today, then you can listen to me talk about all the things for 2 hours. So I'm going to kind of hit, first off, just the general anatomy of the pelvic floor, the abdominal wall, how those things are changed during pregnancy. And then, we'll talk specifically about diastasis recti, prolapse, and pelvic pain, which are 3 of the biggest topics that are becoming more prevalent in the conversation about women's health. But for years and years and years, historically, no one has talked about this stuff. And so women, they have their baby and they leave and they go about their life and they have all these weird things happening in their bodies. And everyone just figures it's normal. It's happening to all of their friends. So they're embarrassed about them. They don't want to talk about them. But when they do talk about them, everyone's like, oh, yeah, I pee every time I jump too. Like, that's just normal. We're moms. We had babies. Like, this is just what life is. And a lot of times the medical community sends that same message. So the reality is that doesn't have to be the way it is. And unfortunately, in our country, physicians don't refer to rehab after birth the way that they would refer to rehab after any other trauma or injury to the body. We would like to change that, but that's the way it is right now. So I want to educate you guys on some of the things that you might be coming across in your own body. And I love the tagline too, like once postpartum, always postpartum. So whether you're 6 weeks postpartum, or you're about to have your second or third baby, or you are 10 or 15 years postpartum, these are issues for all of us that many of us deal with. So I'm going to start off with diastasis recti. I got a couple specific questions about that, and I know this is one that people, it's a very hot topic in fitness, in the fitness industry, especially in the mom fitness industry and female fitness industry for the past 5 to 10 years. So I want to kind of dispel some myths about that and then give you some tools as you go about trying to address it. I think it's an issue for you. So what is it? Just to put it very briefly, when you are pregnant or anytime that you have a big increase in abdominal girth, you can get separation of the two sides of the abdominal wall, the muscles on either side. So you have matching sets of muscles on either side. And then you have a big linea alba ligament fascia that goes up and down the center of you. So that will stretch as your abdomen gets bigger. And with pregnancy, it definitely gets a lot bigger. So as that stretches and widens, there's a lot of load through it, a lot of tension through it. Your body is working very hard to compensate for the fact that there is so much more load out through the front of you, that linea alba will widen and stretch. And so after the baby, we expect to see that come back, in like about 6 to 8 weeks. We expect to see that gap kind of start to heal and close. And I just did, if you didn't see my Facebook Live that I did on Friday, I went through in great detail how to test yourself. And I talked about a lot more detail on diastasis. So if you're interested in that topic, I would refer you back to the Facebook Live that I did. It's like 40 minutes long. We don't have the time to go through a lot of that in detail today. But that's generally what it is. It's a stretching out of that central tissue, a weakening of the fascia, and often compensations that happen through the muscles of the trunk that then don't necessarily resolve the way that they should postpartum. And that can persist for years. The research, unfortunately, as with many women's health topics, research is evolving. There's not a lot of research on diastasis. So I always like to warn people, there's a lot of information out there on the internet, but a lot of it that's making big claims like, my program is going to fix your diastasis, no matter who you are or what you've been through. Those claims are usually unfounded, and they're well-intentioned, but the reality is right now in the medical community, we have more questions than answers about this condition. So the more we treat it, the more we learn about it, the more research that's being done, the more questions we have. And we're just not at a place yet where we can make big blanket statements that give you definitive answers to all of the questions that you have. We have a lot of the same questions. So what I want to do is kind of, first of all, let you know that. And also a big point is that it is, what we do know is that it's multifactorial. So there are going to be lots of things that contribute to a diastasis. It's not always just you were pregnant, your linea alba stretched, now you have a diastasis, and it's just about your six-pack muscles, and we got to bring them back together and make your core really strong. Like, we know that that's not the whole story. It's multifactorial. It has to do with your posture, your mechanics, how you manage your pressure in your system, how you breathe, other injuries that you've had in the past. Do you have a congenital hernia that you've had since you were born, So there's all kinds of factors. Other congenital things like Ehlers-Danlos syndrome, where you have very lax ligaments, can contribute to it. So there's really a lot more factors than just one. And because of that, the fix for people is going to be different, right? So that's where you get people saying, my program fixes everything. No one can say that, because it's going to be different for different people. So that's where, and a lot of these online programs are fantastic. They're wonderful and they have great information. What I usually tell people is, if you tried one of those programs and it didn't work for you and you didn't meet the goals that you had, you're not back to doing what you want to do. You're not back to looking how you were feeling, how you want to feel.
Right.
Go get individually assessed by someone who treats a lot of it, because you may be different than the person that program was really designed for.
Right.
There may be something that's hanging up your progress, right? So the question that I had, specific question, and I get this question a lot is, is surgery necessary?
Mm-hmm.
How do I know if I need surgery? And then what can I do to fix it if I don't need surgery, right? So these are the big questions that we don't have great answers to in the medical community. What I would say is that in terms of exercise, the good news is there's really not, the more we learn, we don't as much make blanket statements about like, you can't do X, Y, Z. Mm-hmm. At least after that 6 to 8 week, or I would say potentially 12-week, early 4th trimester period where your abdominal wall is really still recovering. There's not a lot of stuff that's blanket statement off the table for everyone. Mm-hmm. So if you like to plank, let's see if you can get back to planking. Like, it's not necessarily contraindicated. Mm-hmm. So that's the good news. And kind of big picture, we need your core to be able to handle and transfer load through your trunk, through your rib cage, your pelvis, and your abdominal wall to your limbs and from your limbs. You need to be able to transfer that load without overloading the tissue, with good tension going through your midsection. So if you can do a movement, for example, a plank, transferring with good load transfer, we don't see doming or tenting or bulging, or like you don't have incontinence, you don't have pain, mm-hmm. then it's fine for you to do it. And we actually want you to do movements that tension that tissue well, because it is well known in the human body that when we tension tissue, it stimulates growth and healing of that tissue. So we want to stimulate the fascia and the linea alba in a way that is going to encourage it to grow stronger and build better tissue. Mm-hmm. But we don't want you to overload the tissue in a way that is going to then cause that to be more of a problem. Yeah. So kind of the big picture is, there's not going to be a magic set of exercises. Mm-hmm. Right? There's ones that I'm partial to. There's ones that my colleague, Dr. Jessica, is partial to. There's ones that another PT might use that they're partial to. And we all have our clinical reasons for that. But there's not going to be like a magic set of exercises that are going to make you better or not. It's about how are you doing them and how are you using your core and your whole body when you're doing them.
Right.
So I think that's good news.
Yeah,
right?
It is good news. And it's hard to know when you're on your own, though. Like, are you doing it?
Yes.
Like you're watching something and you think, oh yeah, I'm doing it. And it's like, maybe not.
And that's where, self-assessment will get you so far. But if you're not getting the results that you want, you just need to go and be assessed.
Yeah.
You need eyes that are trained to look for it, to be on you, mm-hmm. And potentially hands on you. So you must be able to engage your core and tension a ligament. That tension will stimulate healing. And the other thing I want to tell people is this can take years, right? So there are some fabulous, I love Get Mom Strong is an Instagram profile that's out there. She had a very severe diastasis after having twins. And her messaging is just so positive about her journey of recovery. And she's so real. And I just love everything that she puts out. But she's very much about like, this took 2 years of hard work. You have to put in the work, you have to put in the effort, especially if it's a more severe situation. Yeah. It can take, it's not get your body back in 6 weeks. Mm-hmm. It's just not.
No.
Some people will. Some people will not have a severe diastasis, and they will get their body back very quickly. But you guys, please don't compare yourself to your icons on social media or to your neighbor down the street or your best friend at the gym. Like, it's not healthy to compare yourself, because for some women, this can take years to recover. And for other women, it just comes right back. And it's what you were given. Yeah. Right? It's not always your fault.
It's not a symptom of your fitness or your health either, right? It's just
not necessarily.
Yeah.
Yeah. It could be, there's a lot of genetics in there. Yeah. There's a lot of factors. So, it's not you did something wrong. It's, okay, this is where you're at. Now, what can you do to move forward?
Yeah.
Right. And it's never too late to move forward. That's the other good news. People always ask me, well, I had my baby 6 years ago. I know I've had this the whole time.
Yeah.
Can I still do anything about it? And we'd rather get you sooner than later, because you can develop all these compensatory patterns and things that we then have to work through in addition to just the diastasis. But, so we'd rather get you sooner in that 4th trimester and start working with you then. But if you're 6 years out, that doesn't mean it can't get better.
Yeah, right.
So The other thing that people always ask me is along those lines, well, when do I know if I need surgery?
Mm-hmm.
And the hard truth of that is we don't have a protocol yet because we don't have the research to say who's going to need surgery and who's not. Because some people will. Some people, it's too stretched, the integrity is lost, and they should have it surgically repaired, right? So that's a real thing. I find in my practice that it's a very low percentage, but we don't know the exact percentage, and we unfortunately don't have great indicators yet of who's going to need surgery. So the general recommendation right now is, even if you have a very large diastasis, you should do some rehab first and see how far can you get. And if you can't get where you want to be with rehab, then great. Your provider should help you decide, like, hey, we've done everything we can do. It's time to go get a surgical consult.
Yeah.
So a good provider will help you decide that, and when the timing is right. But again, like, this is not a decision you should make in 6 months after having your baby. This is like 2 years after having your baby, or at least a year when you're done breastfeeding, when your ligaments and your hormones are gone back to normal. So this is not like a short term, if I'm not where I want to be in 4 or 5 months, I might need surgery. Like, I would give it longer than that.
Right.
And that's what most of the experts are saying. Mm-hmm. And then again, like, it's work, right? So if you're in the camp where you're like, I don't want to do the work, then, I mean, you got to be willing to put in the effort to make some changes.
Right.
Also.
But I know had surgery, and you don't want to have the surgery either. It was not easy.
It is not a fun surgery. It's a huge scar. They always do a tummy tuck with it. It's in the U.S. still typically considered it's an elective surgery, right? So you're going to pay out of pocket for the most part. It's not a fun recovery. And unfortunately, we wish, again, that surgeons, it's mostly plastic surgeons that are doing it, they ought to be sending to PT before and after the surgery, just like any other major surgery, but they don't. So, you go in with potentially a lot of compensation and muscle imbalance, and you come out with the same compensation and muscle imbalance that you had going in. So hopefully, yes, the surgery is, everything's like well brought together and sewn up, but you could potentially not have a great outcome if you have had a lot of compensation happening in your system for a long time. So, so I think hopefully that answers the question that someone sent to me, was primarily like, hey, what about surgery and what exercises can I do? So, there's a lot of great exercises out there, a lot of great programs out there. My biggest recommendation is to get some exercises that are specific to you. And it's not all about strengthening either. If you have tight muscles that are keeping your front midline from closing, like if you have tight lumbar spine, tight obliques, if you have tight hip flexors, like there can be tightness that's contributing to your diastasis not closing. So it's not always about, I need to get stronger. Sometimes it's about, we need to release some things and then retrain how to move in a way that's not going to tighten those things up again.
Right. Yeah.
Right. Then your diastasis can potentially heal a little bit more.
Yeah. And talk, just before we move on, why is this important? Like, what, because, I think that a lot of, like you said before, like, we have babies and this is just part of the, this is just what we're dealt, like, it's what we got to deal with, so why should we be caring about this? What's the importance? I think, like you said, it's just, it all gets kind of just pushed aside, mom gets pushed aside of like, oh, just suck up like a baby, like that's part of the deal.
So from kind of the popular perspective is that people don't like the way their bellies look.
Right. Yeah.
Right. That's what I hear the most. They're like, I don't want to look like I'm 5 months pregnant anymore. So one part of it is certainly aesthetics, but from a more functional standpoint, which we care probably more about as physical therapists, is if you don't have any integrity in your midline and you can't use your core effectively because you have a big loosey-goosey gap here, even if you don't have pain or symptoms right now, the chances that you're going to develop some later are pretty high, right? Because you've lost the integrity of the ability to control your midsection, and that's going to impact your lumbar spine. It's going to impact potentially your thoracic spine, your rib cage, your pelvis, your organs that sit inside or could potentially be, there's no support there. Bowel function potentially can be related. So there's all kinds of things that may be related. And again, the research that we have is very like not conclusive about does diastasis cause this or that. Like the research isn't very conclusive. We see some correlations. We see some lack of correlations where we think there should be a correlation. Research is kind of a funny thing. But it's important because, we know that if you don't have any core strength or you can't connect with your midsection, there's got to be fallout for that later somewhere else in your body, right? So if you have a weak core, back pain is a huge one, but you can also have abdominal pain. You can have shoulder pain if you don't control your trunk well. You can have hip pain. You can have, so we need this part of our body to function well. Otherwise, other things are going to break down.
Right.
So, some moms, who are potentially having, like I said, like shoulder pain, and they're 8 years postpartum, and they have this rotator cuff sprain that just won't go away. They've been to PT, over the years 3 times, and it always gets better with PT, but then it gets worse again. Like, has anyone ever addressed your core in physical therapy? Because, if you have core dysfunction, it's like the foundation that the rest of you works off of. And if it's not there, everybody else in your body is struggling really hard to do their job.
Yeah, for sure. Well, thank you, because I think that, it needs to be out there that we need to take care of ourselves. And, I think that's such an important point, that, because this was not, I started having babies 15 years ago, and this was not, I recognize like, do this, like it shouldn't look like a sunken hole when I lay down, like what is going on, and I researched, but it was not, like you said, it has become more prevalent, but I still don't think it's something that people are really assessing unless it's like a really serious problem, and then it's late, versus it should just be part of postpartum care, right? We need to put this back together.
Yes, and absolutely, and there are some countries in Europe where every single woman goes to pelvic PT for 6 to 8 visits after her baby is born, regardless of how her birth was. And that's just not done here. And it's very unfortunate, but, it should be. We should all be getting assessed after we have a baby, because your body doesn't just go back to the way it was.
Yeah. And you think all the doctor appointments you had before that birth, and it's like,
you're done.
You're done.
See you later.
And it's like, oh, it's supposed to all like magically, like, okay, it's back together. Like, well.
And unfortunately too, a lot of physicians are still saying, the younger ones, I think, maybe are not doing this anymore. They're learning a lot more in medical school about the fact that there's things that women should and could be doing for these things, but a lot of the doctors didn't ever learn that in medical school. And so they're still telling people like, you probably will need a surgery in a few years. It's not going to be covered by your insurance. So, and I had a surgeon tell a client who had done some surgical consults before she came and saw me, a surgeon told her, like, there's nothing, you can do whatever exercises you want. Nothing's going to make it better or worse.
Oh.
And that's just not what we see.
Yeah.
That's not what we see work with people. So, and we don't have research to say that either. We don't have research to say you can do whatever we want. And we don't have research to say, hey, X, Y, and Z is going to fix it. But common sense says you probably shouldn't be doing whatever you want if you have this massive strain in the middle of your abdomen.
For sure.
So,
yeah. So we have someone agreeing. Busy Bee +3 said that she had PT after baby 2 and 3, and it helped so much. So she agrees that getting checked and seeing where you're at is a good call. So
first move. Yep.
Yeah.
Even if PT tells you, you know what, you look great.
Yeah.
Great. Then
Yeah, seriously. Yeah.
Then So let's go ahead and we'll go to our next guy on our list. Are there any more questions on that, Jill?
Not yet. No, we're good.
Okay. So we'll go down to prolapse. So prolapse is much less in the news and in the press and on the social media. Although there is, if you have prolapse, there's an awesome account you can follow called Pop Uplift. And it's a couple of pelvic PTs that do it. It's phenomenal. So I would refer you to that for sure for a good positive follow if you have prolapse. But the kind of common symptoms of this one, less people are familiar with it. Incontinence is going to be huge. So incontinence, which is any leakage. Okay, so any leakage of urine or stool or gas is incontinence. It's not normal. It's very common, but it's not normal. And it's an indication that something is not right in your system. So please always get it checked out, and preferably sooner than later. Same as with diastasis. We can do, it's much easier for us to help you fix this earlier than it is 20 years after. So please, please, please come in early. But incontinence, heaviness, feelings like your vagina is falling out, feeling like it's just kind of loose in there, like you're sitting on a ball, like there's just something there, or potentially women will see it. I've had actually a few people who postpartum, like, you know, a month or two postpartum, they're standing in the shower and all of a sudden they decide to look and they're like, there's like something there. I'm like, wow. Yeah. You probably want it, you know, that's probably what this is. So there's something there, you feel loose, it feels jiggly, like if you try to go back to running, you try to go back to any kind of impact, it just kind of feels loose down there. It's something that people feel. You can also get low back pain, weird, like big pelvic pain, lower abdominal pain, groin pain. There can be bowel issues if you have prolapse. So essentially what it is, and I totally forgot to do my general intro that I was going to do, Jill, that we talked about. I just dived right into diastasis. But so here is your pelvis, right? So inside your pelvis, you have your uterus, right? Is on the top here. And then below that, oh, my organs are all jumbled down here. So you've got your uterus sitting on top of like your bladder, right? And then your rectum is kind of, you guys can see that back there in the back, right? And then you've got all these lovely muscles going every which way. That's your pelvic floor, right? And there's a lot of fascia and ligament and nerves that go in there too. But that's kind of a very simple, pure view of it. So these passages, the vagina and the rectum come down through there. The prolapse, pelvic organ prolapse, is when you have one of those organs, whether it's the bladder or the rectum, or it can be the uterus less commonly, or the urethra. Those things will kind of settle, press down into the vaginal walls. And then what you see is the vaginal wall descending. Okay, so you're not looking or touching your bladder. You're looking or touching at the vaginal wall, which is being pressed down by the organs or tissues above it that have descended. And usually that happens because of pressure over time. Okay, so you can get this condition if you haven't had babies. You can get it if you've had a C-section. Chronic constipation, chronic coughing, and poor habits of managing your pressure are some of the biggest risk factors for that. But obviously, birth story and birth injury. So for example, if you had a grade 3 or a grade 4 tear, you're at a lot higher risk for prolapse because you've got things that have literally like torn away from the pelvis or from their connections. And so it's going to be a lot easier for those organs to sink down because you don't have this good support, right? The same genetic things that would contribute to a worse diastasis can also contribute to prolapse because you're stretchier than the average Joe. So the descent of those things, especially after a vaginal birth, you know, you're pushing. If you push for 3 hours, you might be at higher risk than your friend who pushed for 20 minutes, right? Because especially if you're using a breath hold when you push. So, you know, pushing techniques are important, right? When you have your babies. So we can sometimes help with that too. But so that's what a prolapse is, if you're not familiar with that term. And again, not a lot of great research on prolapse because it's not a glamorous thing for people to research. In the medical community, there's 4 grades. Typically, the grading that physical therapists use is a little bit different from the grading that OBGYNs use. But there's 4 stages. A 1 or a 2 is really very mild, and it's very common after having babies, especially in the first year. Most women, we will observe some descent of, usually it's the front wall of the vagina where the bladder is. A grade 1 or a 2 would be a fairly mild descent, and it will usually always, the prognosis for physical therapy for corrective exercises is very good. So these, you know, if you have a grade 1 or a grade 2, you shouldn't be too stressed, but let's treat it kindly so it doesn't turn into a grade 3, right? Because a grade 3, your prognosis is not as good. These are the ones where you're going to be probably a little bit more symptomatic. Rehab's going to take you a little bit more time and effort. May potentially be looking at something like a pessary, at least in the short term, if not in the long term. we probably will want you to at least have your OBGYN look at it to make sure that it's like in your chart and in your history, and they can track it 10 years from now. Has it gotten better? Has it gotten worse? And then if stage 4 is something that is not very common early postpartum. Usually the stage 4s are when you're 60, 70 years old. If nothing's been done about it, and over time you've continued to have poor pressure management strategies, you've been a breath holder, you've been lifting heavy stuff and holding your breath and have terrible posture and terrible mechanics when you do those things, then when you're later in life, your stage 2 or 3 potentially turned into stage 4. That's where literally like you can't even barely push it back in. Yeah. Your entire vaginal canal is like outside your body. You're a surgical candidate, right? I am not going to fix that. As much as I might try, I can't make you strong enough to pull all of that back up inside you. So I would prefer to get you right after you had your baby, when you're a stage 2 or maybe a stage 3, and teach you how to manage that so that it doesn't turn into a stage 4, right? Because then you potentially don't need a surgery if you can keep it or make it better, right?
Yeah.
So
sure.
Those are kind of the grades, which I think a lot of people don't understand. There's a lot of stress around prolapse because no one has told any of us that it's even a thing until you have it. Because usually it's the women that are very symptomatic who are going to go in and actually get checked, and then their OBGYN might tell them, oh yeah, you've got a mild prolapse, but you might need surgery in a few years, but there's really nothing else you can do about it, just because that's the way our medical community is. Again, like in other places in the world are a little bit better potentially about referring. I know the UK is really good about referring women to physical therapy, and France is really good about that for these types of conditions. But your OB or GYN won't always tell you that physical therapy is an option for this. Right. So, a lot of women aren't getting it checked. It's not a regular part of your screening at your GYN, at your postpartum visit, right? Or even at your annuals. When I had my first baby, not only did they not check me at my 6 week, and I love my providers, by the way. It's just not standard of care.
Yeah. Right.
They didn't check me at 6 weeks. And at my annual, I said, hey, will you please check me for this? Because I just want to know where I'm at before I get pregnant again.
Yeah.
And it's hard to screen yourself. It's a hard test to do on yourself. So I asked the nurse practitioner to do it, and I had to walk her through how to do the test. So, sometimes they're not even trained how to test for it. They're really not testing for it in young women at all.
Yeah. Yeah. I mean, it's incredible what a mystery the after is. That was the most shocking part of it to me when I was one of the first of my friends to get pregnant, and I was just like, you guys, you have no idea what this is really going to be like. Yeah. No one talks about it. No one talks about it. No one prepares you. And then, even just the rehab that should be happening isn't, like you said, isn't standard. We're not addressing it. We're just hoping that it all kind of gets put back together. So I'm so appreciative that you're doing this and I was trying to get so many pregnant moms. I'm like, you guys need to know this. Eddie, it's so much better when you have the information beforehand, rather than figure it out when you have a baby, and now
that's not the time. That's not the time to have to be researching what the heck is going on down here, right? You don't have time. You don't have time. You're tired. And you don't know who to believe. And that's why we get women coming in 5-10 years later, and now their prolapses, they've been living with it. Their diastasis is terrible. Their prolapse is bad. They're stressed about it. They've been depressed for 2 years because they can't run. And that was always their stress reliever before, but now they can't run because they pee and they feel like they're falling apart. So again, and I would say even during pregnancy, I would love to see women come in once during pregnancy so we can tell them, this is how you try to avoid this stuff. And then if you have XYZ, you need to be concerned and ask your GYN for a referral, or just come in and see us. We think obviously everyone should come in. But so with prolapse, again, I know the question I got prior was, what about surgery? Does everyone need surgery? So it really is going to, again, this is an individual thing. There's multiple factors, multiple ways we can go about treating it. The same stuff doesn't work for everyone. So the one of the biggest things is, do I need a surgery, is what great is your prolapse. Because if you're stage 4, you're probably going to need a surgery. But I still think you should do some rehab first. And when I worked for Kaiser in their pelvic rehab department, they did have, you know, the Urogynes would send women to pelvic floor PT, even if they knew they were scheduling the surgery. But you're still going to go to a few visits of PT because we want you to learn how to not be constipated. We want you to learn how to stand without so much pressure on your pelvic floor, how to not hold your breath, how to exercise without making this worse, how to activate your pelvic floor so that you can start doing that as soon as possible, you know, and getting those muscles stronger, because the stronger the tissues and the muscles are inside the pelvis before the surgery, just like any other body part, the better the outcome of the surgery is going to be. And the outcomes for prolapse surgery are not amazing. Always. So, you know, with a knee, if you have a total knee, know your knee is shot. You're going to have your total knee replacement, but you still go to 6 weeks of PT first. And prolapse should be the same, right? So, yeah. So I think the other, I can't remember if there was another part to that question. I think she mostly was like, do I need surgery? And it's really going to depend on what stage, how severe, and symptoms do not always correlate with how severe the prolapse is. So you can have a stage 3 and have hardly any symptoms, and you can have a stage 2 and be really symptomatic. And I have seen a few women who, you know, in that first year postpartum, it's so minor. I'm like, this is so mild, but it bothers them a lot. So we still want to address it, right? Especially with my athletes, like my CrossFitters, my marathoners, like they want to do these high intensity activities, and it's very bothersome and stressful that they can't because they don't feel right? So we want to address that. Even if the stage is mild, like let's figure out how we can get your body working again so that you're not feeling it so much.
Right. Yeah, for sure. For sure.
Yeah. Any other questions about prolapse?
No, not yet. I think you're doing a good job. Yeah.
All right, good. Everyone's like, oh my God, I didn't even know that existed. So the last big one I wanted to hit on is the technical word for it is dyspareunia. And that's a fancy word for pain with intercourse. And pain with intercourse is just one little part of what is known as other types of pelvic pain syndromes. And they can often be chronic. So we do see a lot of women who have never had babies that have chronic pelvic pain syndrome, where they've had had pain with sex their whole lives. They always thought it was normal, unless they saw a GYN about it and they found something anatomically, some kind of reason for that, which there can be a lot of reasons for it prenatally to have pain. A lot of times emotional trauma. But from the pelvic floor standpoint, so if you think about, here's your pelvic floor, right? I love this diagram. So this shows like the different layers, the deeper ones, and then the more superficial ones. But of note, right, we've got muscles that go right around the vagina that attach the vagina to the sit bones. These are the sit bones. And then deeper inside to the tailbone, to the pubic bone, to all sides of the pelvis. So if you have spasm or tightness or tension in these muscles, it makes sense that anything going in or out is potentially going to generate pain, right? So if you have pain with bowel movements or pain with intercourse, and you see your OBGYN and they're like, nothing's real, we don't find anything, right? There's nothing anatomically or medically wrong with you. Very likely you've got some kind of irritation or inflammation of the muscles, the ligaments, the nerves that are inside your pelvis, right? And again, these muscles don't work in a vacuum. They work with the rest of the muscles in your trunk. So your abdominal muscles, your glutes, your hip flexors, your diaphragm is huge when it comes to abdominal wall and pelvic floor function, generally speaking. So we can't just look at only your pelvic floor and say, and fix it, right? We need to look at like the whole system and how it's working together and why is your pelvic floor so spasmed, right? So during pregnancy, there's a lot of reasons that can happen. And then postpartum, there's a lot of reasons that it can happen. The biggest ones, I think, are, scar tissue, right? So if you have a tear, if you have a vaginal delivery and you have a tear, you very likely will have some scar tissue. And some people are going to scar beautifully, and they're never going to have any issues with their scar. And some people are going to scar horribly, and their scar is going to be really sensitive. Even if it might not be a deep tear, it might be really sensitive and need some rehab. Or it might be a stage 4 tear, which goes like all the way through all the layers. And then you really need rehab for that. because that can cause all kinds of incontinence and other stuff too. But there can be scar tissue, which can be very sensitive. It can pinch on nerves. It can do all kinds of things that are not happy. But one of them is cause pain with intercourse, right? There can also be spasm in those deeper muscles they'll spasm further. And especially if you had a traumatic birth, if you had a traumatic C-section, and you have this trauma that's been part of your psyche, your emotions, and your physical body, and your body can't let go of that afterwards. You can have scar tissue from your C-section, from the uterus all the way down, right? You can have scar tissue that contributes to this, but you can also have a lot of muscle spasm and a lot of tension just from the trauma, right? If mentally and emotionally you have not been able to let go of that need to protect, that kind of fight or flight response in your pelvis, then that can hang on for a really long time. Even if you didn't have a vaginal birth, these muscles can still react poorly.
Yeah. To that,
so, so pain with intercourse is a big one. And one of the biggest things, I wanted to give people some tools, and I totally forgot to do that with the prolapse and the diastasis issue, but one of the biggest ones for pelvic pain is breath, because when you breathe, your diaphragm, the motion, we talk about diaphragm, is very connected to the pelvic floor. And when you tune into your diaphragm and your breath, your pelvic floor is automatically going to get some nice excursion up and down, some lengthening and some shortening. When you relax your abdominals, your pelvic floor naturally wants to relax. When you breathe, when you take those slow, deep breaths, you're kind of down training your central nervous system. So you're shutting off your fight or flight response and moving toward your rest and digest response. Your pelvic floor is more prone to relax, right? So breathing is breathing meditation is one of the biggest things you can do on your own to start trying to tune into, can I actually feel what it feels like to have the muscles around my vagina just relax?
Yeah.
So a lot of us just block out that whole part of our body.
Mm-hmm. Yeah.
Right after birth,
right.
But you can't block it off and expect it to function normally all the time. So we need to reconnect with it, with how to contract it as well as how to relax it. And then a lot of times, some internal myofascial release, muscular release, things like that. One of the other things that contribute to vaginal pain, and not necessarily pain with intercourse, but I've had a couple clients where they try to go back to running and they're like, every time I run, I get these stabbing pains in my vagina. Like, what is that about? So that can be, your pelvic floor when you're running, that impact for various reasons. Your pelvic floor is fighting for its life to try to stabilize your pelvis when you're running, and it's not ready for it. And so it's yelling at you to stop. And people just have no idea that there's muscles in there that can cause these types of pains. So if you have if you stopped running at 5 months postpartum, you haven't done much strength or conditioning since then you rest for 6 weeks after you have your baby. And then your doctor says, go run. You're fine. You're good to go. You're medically cleared. You go run. Well, you have not been strengthening any of your running muscles.
Yeah.
Right? For 6 months.
Yeah.
And then you took your core and you blew a hole in it. Right? Either through your abdomen or your pelvic floor, you blew a hole through it. Right. And now you're expecting it to stabilize you with impact when you do something you haven't done in 6 months.
Yeah. Yeah.
So this is where rehab, it's not 6 weeks and then go back to everything you were doing before. It's what can we do in those 6 weeks to now promote recovery, promote healing, help to fill in what's gotten weak and out of conditioning for the however long. And that way, by your 6 week mark, we can start to introduce things again at a little bit more normal level. But that's why I always tell women when they ask me, like, when should I come in after having my baby? I'm like, probably around week 3 or 4. We're not going to do a vaginal assessment. Yeah. But we're going to look at everything else. Mm-hmm. And see where and we're saying, what can you start doing that's going to promote your healing versus hurt you, and educate you on, okay, if it's CrossFit, if it's running, if it's Pilates, if it's dance, whatever it is that you want to go back to, where are you at in potentially your journey for being ready for that? And how can we make proactive steps to get you ready, before the day that you actually want to go? Right. Yeah. Yeah. And I think that's, that also talks to the benefit of going before too, like just so you can
kind of have an idea of where you're at, before the baby comes out and what might be an issue for you. And, so you're prepared.
Yeah.
And because, yeah, it's so much better to do it when your brain is not
Yeah.
foggy, you're not
Yeah.
distracted. So you can remember like, oh yeah, could be. So
yeah.
we did have a
I
question.
listened to a podcast that, I listened to a podcast that said like the time to learn how to connect with your pelvic floor and your abdominals is not after you just had a baby.
Yeah. Yeah.
It's before.
Yeah.
Because it's way harder afterwards.
Yeah, right. For sure.
Way harder.
Yeah.
Yeah. Sorry, what was the question?
We had a question about, and I think you addressed it, but we'll address a specific question about pain or discomfort with a tampon only, but nothing else.
Yeah.
So with that, I think you answered that with like the running scenario too, but that was this question.
Yeah. And then it can be there. The other thing to think about with tampons is, all tampons are not equal. So there can be chemicals in a tampon that is more irritating to your vaginal wall, your chemistry, than potentially your partner, right? Then skin is. Lubrication can certainly be an issue. But if you're not having pain with intercourse and you are having pain with tampons, I would maybe try a different, like maybe a natural or organic brand and see, could it be something in the tampon itself? But also the friction of a tampon can make a difference. And then also, there's a lot of things that can be that can make a difference, right? Why it would be just a tampon versus other things. But shoot, I had one of them at the tip of my brain. Potentially, your muscles having to hold onto that for a very long time, or if the way that tampon is sitting is just rubbing on your scar in a way it doesn't like, right? Yeah. So there could be a lot of reasons for that. It's an interesting presentation though, just with a tampon and not with intercourse is an interesting one.
Yeah. Well, we're all different, right?
Yeah.
Yep. And there could be something to that length of time, right? Like it's sitting there.
Yeah.
If it's in the wrong spot for 4 hours, like.
Yep. And if you have a prolapse, right? So if you have tissue that over time is like then rubbing on it, like loose tissue that's kind of closing it and rubbing on it, or if you have a nerve that's exposed, like right where that tampon is sitting and a nerve that's irritated. But I would definitely look, a quick check for the individual would be like, try a few, maybe other brands, and see if it's potentially just the brand that you've used in the past.
Yeah. Good point. Cool.
Other questions that have popped up on there?
No, that was the only one so far on that one. So fun stuff.
Okay, cool. So I did want to give a quick tip for prolapse, because I know one of my good friends was possibly going to tune in, and she just was one of those women who told me like, I think I have this. She's just a few weeks postpartum. I saw it in the shower, and so with prolapse, one of the first things I have women do, it has nothing to do with trying to strengthen your pelvic floor or do Kegels, okay? It's to look at your posture, because we talked about how your pelvic floor doesn't function in isolation. And our posture, everyone that comes into my clinic postpartum, I say, how do you feel about your posture after I look at it, right? Before I tell them anything, I say, how do you feel about your posture? And most women are like, oh, it's terrible. Yeah. So it's like, your posture is terrible, but do anything about it? No, because we're breastfeeding a baby all day. We're tired. We're, sitting in these terrible positions. We're trying to chase our kids, and we're just, But something I want to mention, because this is huge with prolapse. So anatomically speaking, right, if you have your bladder in a neutral pelvic position, your bladder should be resting, as your other organs should, like nicely on top of this pubic bone. The pubic bone is at an angle, and the pelvic floor is at an angle. It's not like this. It's like this. So your organs are supported on your pubic bone. You have a nice open abdominal wall, and your rib cage sits on top of that in a way that doesn't put a whole lot of pressure down. Now, if you have terrible posture, if you're sitting on your tailbone all day and you're tucked under, right, and then you're slumped over because you're trying to get your breast to your child, or you're just tired in the middle of the night, you're feeding like this, and you're just sitting in a slump posture, right? So you're tucked under here and you're folded over here. Now you can see that it's going to increase the pressure inside your abdomen. And it's also going to cause the bladder to kind of fall off the pubic bone. Now our pubic bone is vertical versus at a 45-degree angle, right? So now everything is sitting just on your pelvic floor that just got a hole blown through it. And so it's very weakened and stretched from that potentially a vaginal birth, right? So if you're like this all day long, not only when you're sitting, but also when you're standing and when you're holding your baby on top of your abdomen, right? Your prolapse could be way more symptomatic because you're going to feel it all the time if that's the way you're positioned all the time. So for a lot of women, all we have to do to get them like 50% less symptoms is say, you need to have your pelvis in line as much as you can during the day, and you need to breathe, right? Because if you hold your breath, again, that increases your intra-abdominal pressure, and a lot of us are breath holding for a lot of different reasons in that early postnatal phase. And if you're breath holding on top of a pelvis that's tucked under, that's just a recipe for feeling a prolapse a lot more than you need to, right? So untucking so that your hip bones are in line with your pubic bone, right? So if you kind of do a little bit of a, pelvic tilt back and forth, and you try to find where does my hip bone line up with my pubic bone so that those two are in a vertical plane, you're probably going to feel like you're sticking your butt out because most women stand like this.
Yeah.
Postpartum, right? Most of us are hanging on for dear life in this position. Our core is not working, so we're just hanging out here with the baby on our hip or on our belly. So huge to just untuck your booty, bring that pelvis into better alignment, and then breathe, right? So let your rib cage open and close on a regular basis like it's supposed to, so that you're mitigating that pressure. And also your pelvic floor and your transverse abdominis and your abdominals, like everybody turns on when you breathe.
Yeah.
So if you are holding your breath, you're really taking away from your body its biggest support mechanism. So you need to be breathing.
Yeah.
So I just wanted to mention that, early postpartum, before you even see anyone, if you're feeling those feelings of pressure, what's your posture like when you're feeling them, or just all day long? Can you correct your posture? Can you think a little bit more about intentional breathing? What does that do to your symptoms? I think that's huge to just start with.
Well, that is amazing. That is such simple information that can do such a world of good, and I think that, and just especially the visuals that you're sharing, it just makes sense, and the fact that we can understand that, simple, the way the body optimally functions is in certain positions doing certain things, and that's not, that doesn't require, it requires effort and some of your time, but again, going into it thinking, okay, I'm going to take time, and we're hearing, self-care, breathing, doing these things for yourself, there are so many benefits to, having your body in the correct position, breathing fully, and taking time to do that. So I just think that is such a great visual and such an amazing message that here's another reason why you could get great, huge benefits from, just taking the time to do this,
Yeah. Yeah. And like you said, it's simple.
Yeah.
A lot of women are like, why didn't I think of that?
Yeah. Well, because
you're not trained to think about it, and you just had a baby. Yeah. Right? Like, give yourself a break. Your brain is fried. That's why we want to see you before you have the baby, so we can tell you all this stuff.
Yeah. Yeah.
And then you already have it in your toolbox.
Right, for sure.
And I know we're running out of time, but sorry, go ahead, Jill.
No, we're good. We got about 10 minutes. You're right. So putting the pieces together, beforehand. I think that's the main takeaway from all this. So it's good.
Yeah. And I would again refer back to so I have that online workshop where I cover a lot more of that stuff in detail for each one of these conditions. Like, what can you do right now today at your house without seeing anyone, that you can start trying to play with and practice to try to make some improvements and see if you can start moving forward from where you're at. And that's a free workshop. And the link is in my bio on my Instagram profile. So I would encourage people to view that. And then I also have an online, like a 6-week kind of 6-week online like rehab program. Mm-hmm. But like I said at the beginning, I think everyone should see a pelvic PT postpartum. That's my ideal. If you can't see one for whatever reason,
right,
then go ahead and research some online programs. Mine, along with there's a lot of other great ones out there, right? But I really think that the ideal, the gold standard is that you can see someone for individual assessment and individual care.
Right. Yeah, for sure. All right, so let's tell everyone where exactly all the places they can find you and follow you so they know where to get, even more great information like this. So.
Yeah, so I have an Instagram profile. It's at SheFitPT. That's the easiest, right? You can link to it. I also have a Facebook page, so you can follow me on there. I have a YouTube channel. So I've posted tons of videos over the years, prenatal, postnatal, pelvic floor type stuff. My website's www.shefitpt.com. We have offices in Pacific Beach and Mission Valley. And we are also now doing telehealth, so we can do virtual visits with anyone in California for physical therapy, and outside California, we can do wellness services. So there's a lot of options for talking with us and consulting and getting some ideas and some care. We do still have a therapist in the clinic. I'm not going into the clinic. My colleague, Dr. Jessica Chavaria, is going into the clinic, but we do have clinic option as well as virtual visits right now. So you can check out the website. You can email me, Sherry, SHERI, at shefitpt.com. And I'm also, if you registered for today, I am planning to send out kind of a follow-up email with a free gift for you guys. I mentioned that my 6-week online postpartum program, I'm going to try to figure out some way to give you guys some free content from that, or some way. I'm going to figure it out. I'm going to figure out a way to give you guys kind of a little bit of that content in your inbox in the next couple of days. So if you didn't register for this today, there's your reason to go register, because if I have your email, I can send that to you. If I don't have it, I can't send it.
Yes. And so for us, we have your YouTube in our bio. We have a link to it. So that'll be up there so that people can look for our account. And then if you aren't able to register and you're watching this later, because this will be up for 24 hours, just DM one of us, your contact info, and we'll be sure to give you the goodies that she's offering. So the free content. So wonderful. Well, I wish I had this 15 years ago. So thank you so much.
My pleasure.
You are doing the good work. So I think it's
having me.
Such an important message to get out there, that there is some rehab to be involved after this magical event, and don't forget about yourself. So I think it's really, really
and it's important, and it's okay. Like you're not alone.
Yes.
So many people, so many women are going through the same thing. But at the same time, like, it's not normal. So yes, please do something about it. And there are things you can do besides surgery.
Yes.
And besides Kegels. Right? I didn't even mention the word Kegel. I don't think. I mentioned it once this whole past hour. So, there's a lot of stuff we address besides just Kegels. So even if you've been to pelvic PT and all you've been given is Kegels, like, not all PT is created equal.
Yeah, exactly. Wonderful. Well, I think this was such important information to be shared, and hopefully everyone will share with a friend, share with your pregnant friends, so they will say thank you for sure. Oh my goodness. All right. So we just got about a minute remaining. Thank you so much, Dr. Sherry. It was so great.
Thanks you guys for joining. I'll see you soon, Jill. Hopefully in person one of these days.
Hopefully come together in person and do it again. So, all right. Well, it was great having you. Thanks for joining me. I really appreciate it.
Have a great Sunday.
Yes, thank you. You too. Enjoy the sunshine. All right.
Bye.
Bye.